Good evening, everyone, and welcome to tonight's Facebook Live. My name is Jazzy, and I work in the research communications team at Breast Cancer Now. And tonight I have the pleasure of being joined by two of our amazing researchers, Professor Claude, Chelala, and Ugomma, Nwadnigwe, to talk about some of the research we fund as a charity that focuses on reducing health inequalities faced by women from underrepresented groups. Claude's a professor of bioinformatics at Barts Cancer Institute at Queen Mary University of London. She's recently published a piece as titled The Clinical and Molecular Landscape of Breast Cancer in Women of African and South Asian Ancestry. And if that sounds like a long title, that's fine. We'll get into it later. And Ugomma is a PhD student at the University of Bradford. She's working on a Breast Cancer Now funded project that's looking at investigating the barriers to breast screening faced by the Black African community in the UK. This session is part of our programme for Ethnic Minorities Cancer Awareness Month, also known as AMCAM. And there is actually another live session next Thursday that will see our nursing team collaborating with Nwadnigwe Anderson, who runs the Rad Chat podcast. So if you're around, please join for that one too. Before we get started, I just want to run through some housekeeping. Just a reminder that if you've got any questions for the researchers or for me, please pop them in the chat below. It is a public forum, so if you post, a question, other people will be able to see it. And we'll do our best during the sessions to answer as many of these questions as we can. But obviously, if we can't get to them all, or there's something where we might need to, do a little bit more research, or we want to elaborate a little bit more, then we can respond to those over the next couple of days. If you want to reach out through us through any other channels like our helpline, the information will be popped in the chat. Now, I've said all that, so please welcome our two researchers. Great. Hi both. How are you both tonight?
Good. All good, thank you.
Great, good to hear. Now, obviously, I've rattled off like a pretty quick introduction to the both of you, but would you each be able to introduce yourself as well and explain just in a couple of sentences what you do and maybe where you work at the moment, what you're working on?
Yes, I'm happy to start. So I currently am Professor of Bioinformatics at Queen Mary University of London's Barts Cancer Institute. I'm a health data scientist, bioinformatician. So what I do is deal with large data sets, clinical data sets, and we connect them to genetic data, molecular data, and we try to understand patterns that could help with early detection, prognosis, and treatment response. My main research focuses on breast cancer, and I'm very much passionate about the impact of genetic ancestry on breast cancer risk, but I'm also interested in breast cancer recurrence, especially in after breast-conserving surgery. So could we predict signals of recurrence that would help us, monitor better breast cancer patients and the relative risk of recurrence.
Amazing. Ugomma, you go.
Hi, my name is Ugomma. I am a PhD student with University of Bradford, and I'm working on co-producing an intervention to increase screening uptake, breast screening uptake for Black African women in the UK. We've done a preliminary review, two systematic reviews, and we've seen that there are limited researches in this area that are exploring barriers to breast screening for this population group. So will be our focus with the research. Thank you.
Great. Thank you so much. Now, obviously, you work on quite different areas of research, but could you each tell us a little bit about what inspired you both to go into research at all?
Would you like to go first?
Oh, okay, that's fine. So, I would say from childhood, I grew up watching my parents throughout their career paths. My parents, my dad retired as a professor in industrial chemistry, and my mom as a professor in ecology. So, throughout that process, we observed them go through their different researches to become to achieve their careers. And in fact, my first job as probably as a 12-year-old was to type up my mom's transcript, manuscript for research. And so the idea of research started building up in me. But this particular research was inspired because I had a close relationship with two Black African women who died from breast cancer. And so when I saw this opportunity, I said, this is a wonderful fit for me to, contribute in this area.
Can I ask, just as a follow-up question, were you doing kind of like similar research before, or was this a bit of a transition looking at breast cancer?
So I've done a couple of researches previously in my master's degree as a health under health economics and health policy, but this will be a transition into a research career path for me. Yeah.
Great, thank you so much. What about you, Claude? Similar? Not
So
at all.
yeah, I think similar in the sense that uh, a strong passion for research and science. I trained as a bioinformatician, so I did my training in France and Paris before moving to the UK, but I was more on the fundamental research side, and what I wanted is to translate the knowledge into patient setting, and this actually encouraged me to move to the UK and join Barts Cancer Institute, where we work very closely with our clinician scientists. Um, so you have research that is designed to address current clinical challenges, and you have the bioinformatician working with the data analytics trying to address those challenges. So it's very patient facing, and I think this is what keeps me going. It's just to see that the research that we do has a translational power, and it could help improve patient outcome today, hopefully.
Yeah, I can imagine that's incredibly motivating. Um, well, let's start with you, Claude. Um,
Mhm.
I kind of already mentioned it in my introduction, but one of the reasons we invited you today is because you recently released a paper that's kind of looking at health inequalities, specifically African and South Asian women. Could you tell us a little bit about what that research was about and how it came about, essentially?
Yes, so an important role and well, an important hat that I wear at work is being the data lead or the health informatics lead for the Breast Cancer Now tissue bank. And I'll talk about that later. But I think this gave us a strong motivation to try and understand health data and patient trajectories. And working on breast cancer, it's I mean there is it's very well established now that racial disparity do affect breast cancer statistics, and we see a higher mortality in ethnic minority groups. Um, Social determinants of health could explain some of this, but not fully. And a major gap, I think, in at the moment is the underrepresentation of patients with breast cancer from ethnic minorities in research studies and clinical trials. And we tried to address this by gathering information on large cohorts of breast cancer, um, women with breast cancer from different backgrounds. So we assembled a cohort of over 7,000 women from different ethnic groups. And we asked specific questions around how does breast cancer evolve and affect women from African or South Asian ancestry compared to the other, well, to their white group or European women. And this is what motivated this study. We tried to understand the blind spots, if you want, the underrepresentation that is just always stopping, the benefit from research studies and clinical trials, stopping the benefits from those studies to be translated to patients from ethnic minorities. Um, yeah, so this is what we've done this, and obviously the Breast Cancer Now Biobank was a major cohort in our study, but alongside the Breast Cancer Now Biobank, we used other UK and US cohorts.
Yeah. Could you tell us a little bit about some of the key findings from this paper?
Yes, so we found that when you compare African and South Asian women with breast cancer, to the European counterpart or the white patients, we found that they present with an age at diagnosis that is younger, so they present earlier. And sadly, the prognosis is shorter than the other group. We found that they tend to present with a high grade disease, so more aggressive. And also, we found that the screening window in the UK, which is between the age of 50 and 70, could miss a higher proportion of younger breast cancer cases in those groups. So I think an ethnicity adapted screening window would help achieve a greater equity in the screening program. We also found genetic changes that could help with risk prediction, but also understand treatment response. So those are markers that could modulate response to treatment by conferring a resistant or a sensitive phenotype. And if those are taken into account in the treatment of those patients, it would maximize the benefit from the treatment strategies. We also advocate very strongly in our paper to more research inclusion for those ethnic groups in research studies. So as we see now from funders that you have the gender dimension in research studies, you have to make sure that you have a balanced and equitable design. I think the ethnic dimension should be considered. So there is a proportion, an equal participation or representation from different groups to ensure that benefits or questions, research questions, could also be translated to all patient groups.
Yeah, I mean, I just pulled up your quote that you kind of like released alongside this research, and you said, if we fail to address blind spots in research, we risk widening health inequalities rather than reducing them. Is that, you think, one of the main takeaways from your paper is around, how do we
Yeah,
address some of these, differences that we see?
absolutely. So we do have blind spots. And I think we don't know enough about how breast cancer develops and progresses in ethnic minority groups. And if we don't address those now, I think we will widen the health inequality quite largely. We have to remember that artificial intelligence is coming to just help with analyzing large data sets and hopefully aid in the clinical settings. But if the AI, for example, is trained on data that is not diverse enough, that doesn't represent those women, that doesn't cover very well the ethnic angle, the gaps are just going to get wider, and this is very risky and very dangerous. So I think it's a blind spot that needs to be addressed on the research side, but also it requires funders, it requires policy. Just every application that doesn't cover the ethnic dimension needs to justify why and have a valid reasons for not doing that.
Yeah. No, I mean, yeah, I think it was really interesting research to read about, that it's definitely like, a little hard hitting to read, like some of the data that you pulled out just about, how underrepresented some groups are in things like clinical trials. And I know you already summarized it, but talking about how it's not just, I guess, like scientists, but also funders need to kind
Yeah.
of think better about how to make sure that the research they fund
Yeah, so I
includes
think
everyone.
the next step is trying to understand the barriers, trying to understand
Yeah.
why they are underrepresented, and try and tackle those. And this is what we're doing in the group at the moment, trying to understand those barriers. But I can talk about this forever, so I hope to just pause now and
No, that's okay.
come
That
back to
actually
this.
flows pretty well into our other researcher, who is investigating not necessarily the barriers, I think, to clinical trials, but your research is about investigating the barriers to screening. Could you tell us a little bit about your project and what you're hoping to do over the next few years at Ugomma?
So, the main aim is to co produce an intervention that will help overcome these barriers and increase screening uptake for Black African women and hopefully other ethnic minority groups. So, the first part of the research we tried to collect as much information as possible to be able to understand the barriers these the target population face. So some of the barriers were lack of understanding about mammogram or breast screening. So they had this concept that breast screening is about self-examination, which could relate to what has been emphasized in their home country. Also, there were other knowledge related or misconceptions about breast cancer itself. And so, some of the participants were of the opinion that once you have breast cancer, that is a death warrant. You should, share your will at that point. And so nothing can be done. So there is a feeling of hopelessness. So it fits back to why then should they have this breast screening. And there were concerns about radiation regarding the mammogram itself. And I interviewed one lady who said, I know it is expensive for individuals to have mammogram. And so you see that there is some sort of lack of understanding about how the health system works, because this population includes those who are maybe born here and second generation or first generation immigrants, you see. So there were also language or accent barriers, and it's even more difficult to get to the population groups that have different languages that is not primarily English. So to get to know their barriers is also an additional layer, additional steps. Then you have those who have had a previous mammogram experience, and they tell you that it is very painful and they would not like to go through that experience again. Some of the participants also mentioned that they wouldn't like to expose their bodies, or they don't want them to have to be questioned about their bodies. Some say, I have tribal marks on my body. So I don't want a healthcare professional to ask me, what does this signify? And are you okay? Is there any violence? They start digging deeper, which is kind of exposes them to a lot of other things. So these are the concerns that I gathered, well, in a nutshell, about the barriers they face. So the second stage of the research will be to co-produce this intervention. So we've seen what the problems are. They also suggested some approaches to help overcome these interventions, to overcome these barriers. And some of the interventions they mentioned, these suggestions they mentioned, is they need to have more awareness. They need to have more representation in the images that are circulated out there to encourage Black African women or other ethnic minority groups to go for screening. So they want that representation. They want something they can easily share, maybe on WhatsApp group, something in a language that they can easily understand. So we have set up that co-production team, making sure that it is well represented. And we have decided on producing a DAISY, which is a digital animation. And so it will have images, it will have different languages, Arabic language, and different African languages as well. And we hope to address the barriers or the misconceptions or the myths surrounding breast screening or breast cancer. And also, it will have a written format as well, so that it can capture wider population, target population.
Yeah, that sounds really interesting. Also, really interesting to hear like such a wide, I guess, variety in the answers in terms of like
Yeah.
what different people's barriers are. I can imagine it's not difficult, but it might be quite a challenge to address all those a range of concerns or questions people might have. Could you tell me a little bit more about what co-production is, and why that's so important to this research?
So, in terms of co-production, we want to ensure that the target population is involved in producing that intervention. So, we involve them in the conception. So even the suggestion of what kind of intervention should be made available to them, what will be the content. So we made sure that the group had Muslim communities represented, Christians, and other African communities as well. And also people who have research background, primary care clinicians as well, breast cancer screening facilitators, so that we have different views and we meet periodically looking at the different suggestions that we bring up, criticizing them, fine tuning them till we have a definite answer to what we are looking for. So it's kind of a process, but the initial and most important part is to get that group that will have these various views to ensure that it is acceptable to all the population group. Yeah.
I mean, that makes a lot of sense. Could you also just talk a little bit about why this research is so important? I mean, maybe I think the answer is probably obvious, but why are you looking specifically, I guess, at Black African women in the UK and screening?
So, yeah. So we first of all did a systematic review to see what research is out there, what the literature is saying, and there is evidence that Black African women have lower uptake of breast screening compared to other ethnic groups, and also, like Professor Claude said, they tend to get the more aggressive types of cancer. And in fact, I think the Public Health England said that 1 in 7 women will have breast cancer in their lifetime. This includes Black African women. And if they're not taking up screening and they're developing this aggressive type of cancers, then they will tend to be diagnosed at later stages where survival or chances of survival will be lower. So this is incredibly important that we try to overcome these barriers. And we hope that it will have a spillover effect to other population groups as well.
Yeah, I mean that would be great. But it sounds like you're already, doing quite a lot of work. I was going to ask you like what are you doing at the moment, but I'm assuming that kind of means at the moment you're working on the sort of the actual intervention production.
Yes, so we've done some meetings with the co-production team. So at this stage, we are trying to fine tune the actual intervention. After this stage, the next step will be to have like a stakeholder event and evaluate the intervention that we've done to make sure that other groups will accept it as well. So that will be next year.
That sounds great. I think kind of following up from this a little bit, obviously you've heard a little bit about both your research and as listeners might be able to hear it, it's quite different types of research that we're talking about here. Just to give people a little bit of insight of what it's actually like doing it, could you tell us, both of you, what a typical day looks like working on, while working this kind of research?
Should I?
You like, yeah, I can
You can go
start.
first, James.
Okay,
So,
fine.
yeah, so days are very busy. So at the moment, the research group is quite big, and we're working on different projects. I think there's a lot of meetings, there's a lot of discussions and excitement, and we try to prioritize what needs to be done, etc. I think there is always obviously running the biobank is very important, but also on the side is also making sure that all the students are going through their supervision meeting, all the discussions or the collaborations. Or so I would say it's a busy, full-on day. I don't know if I'm answering your question, but yeah, it's every day is different, and I think yeah, everything it's
It's hard to answer what a typical
Yeah,
day
you
is.
follow the research projects as they go along, and you design the new hypothesis, and you see where it takes you, and then you design the next step. Yeah,
Or
I
perhaps
think
maybe, oh
in
no, go on.
particular, sorry, in particular for the ancestry, because I think you're asking me about today about the ancestry work. I'm very excited, as I said before. We are doing a large study trying to understand the barriers towards the underrepresentation of ethnic minorities in breast cancer studies. And obviously, working with the Breast Cancer Now Biobank gives us a fantastic tool so that the biobank recruits from different sites in the UK. So we have engagement from different NHS trusts, and you could see the patients that are coming to the clinic, those that are being consented, without whom none of this would be possible, by the way. It's so important that patients do work with researchers and biobanks to make sure that we have a good representation and suitable samples for us to ask questions. So what we are asking is, first, what are the barriers? Are they at the interaction with the biobank? Are we capturing? Are we representative of the demographics of the cancer cohort and the NHS trusts that we work with, or the sites? And what are the barriers? Why are people not consenting? Why do patients choose to consent and others choose not to? What are the barriers? And learn from those and try and tackle them. And then we go to the samples that we have in the biobank. What samples do we hold on those patients? Do we have a good comprehensive set of samples to facilitate research? And then we go to the research applications. How many did we receive that actually included ethnicity in their inclusion criteria? And the papers that were published on samples from the biobank, how many did address health inequalities? How many did look at cancer in different ethnic groups? So at the moment, this is ongoing, but I hope before the end of this year, we will have the first draft. And we have a lot of exciting findings that we are just validating. And I hope this will inform kind of a strategy that we move forward with in the biobank, trying to widen representation and inclusion, but also it will inform and answer very important questions regarding the barriers that are causing this underrepresentation.
Yeah, that sounds like some very exciting work that you're doing. Just for, our audience who might not be super familiar with the Breast Cancer Now Biobank, I know you've kind of said a lot of the things that it does and how it works, but
Yes.
could you perhaps
Yeah.
summarize in one or two sentences what the biobank is and why it's so important?
So I am actually very proud to be part of the biobank. I was part of the biobank since its inception many years ago. We are funded by Breast Cancer Now, based on a gap analysis that the charity has commissioned, assembling scientists from over the UK to address the gaps in advancing breast cancer research for patient benefit. And one of the major gaps was the lack of well standardized patient samples and rich data that are made available to researchers to test hypotheses and generate knowledge and maximize information. So to respond to this gap, the charity funded the tissue bank. Well, the biobank is not just tissue, it's a lot of data, cells, etc. So we changed the name recently to biobank. And the biobank has ethics approval to approach patient consent. So we have informed consent from patient wishing to take part, access to their medical records, and then access to samples. And the biobank will anonymize all this data, so we don't share any sensitive information with researchers. And we have a tissue access committee that review applications from research groups, international research groups, that present a scientific project with a hypothesis and a clinical unmet need or problem they're trying to solve. And based on the remit and the validity of their hypothesis and the importance of their research, they will get access to the clinical samples and data that would allow them to carry on the research. The biobank is just fantastic from the beginning. We've engaged into a very strong data strategy, meaning that we don't want any data to be lost. We just want to enrich the value of samples and make sure that data generated on samples from the biobank will be made available for the scientific community to reduce duplication of effort, maximize output, etc. So we have a platform that has clinical and molecular data from research on samples from the biobank alongside research from similar cohorts with similar data types. So researchers can come, test hypothesis, validate their findings. So I would call it is the one-stop to go platform to go for research on breast cancer to get access to samples, data, but also to look at what output has been generated already and perhaps apply for samples and do matched research and push the knowledge a little bit further. So at the moment, we collect from many active sites across the UK, and we have capacity to, if we don't have the samples and the data that the researchers are coming for, which is very rare, we would just go and work with partners and other sites and try and make sure that the research that has been assessed for scientific and relevance and robustness has access to samples and clinical data to go ahead. We have a fantastic team. It's a fantastic team of consent officers that go to the breast clinic, speak to patients, support them, and talk to them. Then they bring all the information to the acquisition team. We have data officers, we have bioinformaticians, we have pathologists, we have scientists, clinicians. It's a fantastic initiative, and I'm really proud and lucky to be part of it.
No, I mean, you don't have to convince me, obviously. I think the biobank is amazing, but just for anyone who might have no idea what it is, I think that's a great explanation. Right. I want to kind of bring it back to perhaps a little bit of a more general point, which is we've talked about, both your sort of studies, what you're working on, what you've published recently. Is there any other research that's looking at like tackling health inequalities that excites you, or any other things that you're like, it's great to hear, I don't know, people are working on there? If you can't think of anything, don't worry, but I just was wondering if there's anything that you're aware of.
I think there are a lot of efforts in the UK, in the US, in Europe, but I am very excited to learn what's going to happen under the Cancer Research UK Grant Challenge program last year that has funded research on health inequalities and looking at women with breast cancer, bringing together scientists from the UK and the US to work together. So I think watch this space. It's a very exciting, large project that hopefully will help reduce health inequalities and improve our knowledge in the space.
Sounds great. Anything from you, Ugomma, or nothing that you think about?
I think for me, it's more in general long-term disease conditions. I read a report recently from the Health Foundation report about health inequalities in 2040, and it says that those living in deprived areas will continue to have these health inequalities, especially in some long-term disease conditions like COPD, diabetes, and other disease conditions. In fact, even more recently, there's a report that says they are more likely to have emergency admissions. And so I'm interested to see how the public health team will be able to look at how to resolve this and, make sure that we don't widen these health inequalities.
Yeah, I mean, that sounds obviously like that's quite a, I don't know, depressing report perhaps, but obviously highlighting how much work needs to be done, how important research into this area is. Now, Ugomma, I actually had a question from you submitted by one of my colleagues earlier, so I thought I'd just ask you now. Can you tell us a little bit about when your project is like planning to approximately end, or like when you were hoping to be able to share some of these results that you're working on?
So we have submitted one systematic review the first literature review to one of the journals. So we are hoping that will be available this year. Next year, we will hope to publish the two primary studies that we are working on. Yeah. So
It's exciting. And also just a question. Obviously, you're kind of, I guess, like relatively speaking, in the world of science, at the start of your research career, in the sense of, you're a PhD student. There is a whole world after that. Have you got any idea what you would like to do after your PhD, or any other work that I don't know, you see in your future now that you're working on
okay,
it?
okay. If I'm allowed to dream, yeah.
Yeah, of
So
course.
I would like to work with international organizations in terms of research consultancy, looking at WHOs or UNICEF,
Mm.
trying to bridge these health inequalities in different countries as well. So it's a very big dream, hopefully achievable. And or other governmental agencies, UK governmental agencies, or research-based organizations. Yeah, so that's where my eyes are.
I mean, that sounds great. I hope that after the PhD, that absolutely happens. Um, Now, I actually can't see the chat at the moment, but if you've got any questions for our researchers, please do ask them now, because we're going to start wrapping up um, in a second. Um, Maybe for Claude, obviously you mentioned some of the work that's kind of like going on now a little bit. Could you elaborate a little bit more? I know you mentioned at the end, did mention it, I think, but when I read your paper at the end, it kind of mentioned that you want to expand some of the research that you're doing to include other ethnicities. Could you
Mhm.
talk a little bit more about, I guess, what the next steps for
Yeah.
your research are, not just in terms of looking at some of those barriers, but some of the other things that you might be working on at the moment?
Yes, so fantastic question. So I can talk for a long time. I what I'm really keen on is to look at South Asian uh, women with breast cancer from South Asian background, first generation and second generation, and hopefully have a collaboration with um, South Asian countries and look at them at the same phenotype in their home country. I think that would be fabulous. And we're trying to establish collaborations with a few hospitals in India to see if we can tackle this. I'm also talking to different research groups in the Middle East and North Africa region, so the MENA region, where I think there is a need as well for similar studies. And we were approached after the publication of our paper to see if we would like to collaborate where the same framework could apply in those countries where organizations have similar data types and phenotypes, and we can organize this collaboration. So this is ongoing, and I hope by the end of this year we could start effectively working together. So I'm really trying to validate some of our findings, working with understanding, first generation, second generation. I think Ugomma mentioned that as well, and then also work with Indian partners, but also in the Middle East and North Africa, and try to tackle breast cancer in those groups because I think they are also underrepresented in the same way.
I mean, yeah, that's just super interesting. I think it also really highlights, I guess, like the importance of collaboration, and especially in research. Collaboration can often be and is often, across the world, even if people might not be aware of those kinds of things happening. And also really interesting to hear, I guess, you were approached after your paper with people being like, yeah, we've got some stuff
Yeah,
that you might want to look at, that you might, help with your work.
yeah.
I think at the moment there aren't any questions that we'll probably go through tonight. So I think that's all we have time for tonight. Thank you so much for giving up a bit of your evening to talk to us both. It's been super interesting. And to everyone who's tuned in, I hope you found it as informative as I have. Now, obviously, if you've got any follow up questions or you want to know a bit more about the research, or read a bit more about it, please do get in touch. We can direct you to some more information about both these researchers' amazing projects. And just wanted to say that obviously our research is only possible thanks to the incredibly generosity of our supporters. So Ugomma's project funding and the Breast Cancer Now Biobank, which played a key part in Claude's research, and you talks about it loads, are both supported by the Asda Tickled Pink campaign. And if you want to learn more about our research in general, or want more information about any of the other things that Breast Cancer Now does, like our services, our support, or our campaigning, please do check out the Breast Cancer Now website. I'll see you all next time. Well, I'm sure at some point I'll be chatting to more Breast Cancer Now researchers. And in the meantime, don't forget to tune in to next Thursday's chat as part of MCAM. So yeah, see you soon.
Yeah, thank you so much. Thank you.
Thank you.